Important facts about Guillaine Barré Syndrome or GBS which you must know. Number 1. It is not always an ascending paralysis because it affects the nerve root. So this is the dorsal nerve root and this is the ventral nerve root. Guillaine Barré Syndrome is primarily a disease of a radicular neuropathy origin, and therefore the nerve roots are involved. Weakness can begin proximally or even simultaneously proximally or distally. So it doesn't have to start in the feet. Secondly, GBS can involve the cranial nerves. Bilateral facial nerve palsy, bulbar paralysis, ophthalmoplegia are all features of GBS variants. You don't need the patient to have limb weakness for you to say that it is a GBS. The third one, it is not always a demyelinating process. We do have axonal variants and we do have nodal or paranodal variants. New molecular targets which are paranodal proteins like neurofascin and contactin show that some forms are actually nodopathies. So what are the nodopathies? So this is how a neuron looks like. These areas between the myelin sheath are actually the nodes of Ranvier, and therefore this is the myelin sheath and this is the myelin sheath, and in between we have the node of Ranvier. So therefore we have immune targets on these areas, and these forms of Guillaine Barré syndrome actually present between a demyelinating lesion and an axonal variant. Remember, the axonal variants have a slightly poor prognosis. The fourth one, always do a single breath count test on your patient with Guillaine Barré syndrome. And how do you do it? Ask your patient to count after a single maximum breath from 1 onwards without taking in another breath. If they can't count until 20, you should think about securing the patient's airway. This corresponds to a forced vital capacity, and therefore this number 20 is very important. The fifth one, get a nerve conduction study on your patient very early. Features like prolonged F waves, absent F waves, and F wave impersistence, which denotes that this is a proximal radicular neuropathy, are actually very early features in your patients with Guillaine-Barré syndrome. And this can be picked up early before you have your typical CSF changes. So, for example, this is an F wave, and therefore you have prolonged F waves. You can have absent F waves where there are no F waves. And F wave impersistence means that each stimulation cannot generate an F wave. As you can see in this one, F wave is only generated in the first stimulation and in the fourth stimulation. These are nerve conduction findings in early GBS. Lastly, make sure you remember your differential diagnosis. Botulism, diphtheric paralysis, lead neuropathy, porphyria, the acute intermittent porphyria, and organophosphate poisoning. These are important differentials in your GBS. But always remember, GBS is far more common, and therefore any patient who is presenting with acute symmetrical motor predominant symptoms, always think of Guillaine-Barré syndrome.